Hello everyone, today we will discuss psoriatic arthritis. Psoriatic arthritis is a seronegative arthritis which occurs in up to 40% of patients with moderate to severe psoriasis. It is a progressive inflammatory musculoskeletal disease predominantly affecting the distal interphalangeal joint as a distinguished feature from the rheumatoid arthritis where it involves the proximal interphalangeal joint. And a symmetrical rheumatoid-like pattern, arthritis mutilans, a rare severe deformity of arthritis of hands and feet. Axial disease with spondylitis or sacroiliac disease is present. Classification of arthritis. Arthritis may be a inflammatory or non-inflammatory. Coming to inflammatory, it might be a seropositive, seronegative, or infectious and crystal induced. In seropositive, rheumatoid arthritis, lupus, scleroderma, vasculitis, and Sjogren's. Coming to seronegative arthritis, ankylosing spondylitis, psoriatic arthritis, reactive arthritis, and inflammatory bowel disease. Epidemiology of psoriatic arthritis, equal in men and women. Psoriatic arthritis is commonly seen in adulthood with mean age of onset 39.2 years. The annual incidence of psoriatic arthritis is 2.7 cases per 100. The clinical predictors of psoriatic arthritis are nail psoriasis, severe psoriasis, scalp and intergluteal or perianal psoriasis in the presence of uveitis. Clinical features. Cutaneous findings. Scalp psoriasis and intergluteal psoriasis are more likely to be associated with the psoriatic arthritis. Clinical nail disease with a prevalence of 40% in psoriasis is a known risk factor for psoriatic arthritis. In psoriatic arthritis, nail disease prevalence is about 80%. Both the nail plate and the nail matrix are affected, with the nail pitting being the most common finding. Coming to non-cutaneous findings, psoriatic arthritis is preceded by a non-specific musculoskeletal and systemic symptoms consisting of joint pain, fatigue, and stiffness. The clinical spectrum of psoriatic arthritis musculoskeletal manifestations is heterogeneous, encompassing not only the inflammatory arthritis but also the enthesitis, dactylitis, and spondylitis. Coming to arthritis, psoriatic arthritis clinically presence have been described by Moll and Wright as a 5 distinct phenotypes. They are oligoarticular. It is the most common form, the most common type of arthritis. And polyarticular symmetrical, it is the 15%. Distal interphalangeal joint predominant, it is about 5%. And spondyloarthritis, it is about 5%. And arthritis mutilans, it is also about 5%. These phenotypes tend to be overlap with the cumulative disease duration. For example, the oligoarticular presentation tends to become a symmetric over the time and more joints become involved. Spondyloarthritis occur more frequently than previously thought it is in association with peripheral psoriatic arthritis. Correct quantification of joint affected is important for treating and monitoring of psoriatic arthritis. These are the phenotype of psoriatic arthritis. Dactylitis. Dactylitis is a full thickness inflammation of a digit, finger or a toes. Acute dactylitis is a tender. It has a prevalence of 20 to 59% in psoriatic arthritis and a sign of disease severity associated with radiographic damage. Inflammation affects the joints, entheses, and subcutaneous tissues of the digits. Dactylitis assessed with a high resolution MRI is characterized by multiple lesions spanning multiple musculoskeletal structures. And the MRI findings are diffuse extracapsular soft tissue edema, diffuse or focal increased bone marrow edema, enthesitis at the collateral ligaments, and extensor tendon insertions, flexor tenosynovitis, synovitis, and signal intensity changes in the tendon pulleys at the fingers and fibrous sheaths at toes. Dactylitis is one of the criteria in the Casper classification as a result of its specificity for psoriatic arthritis. Dactylitis involving the toes. Here, these are the nail findings. Arthritis mutilans. This is the involvement of distal interphalangeal joint. Arthritis mutilans. And this is the telescoping of fingers. Telescoping of fingers. This is the radiographic finding of a psoriatic arthritis. It is a pencil cup deformity, where this is a splaying of base of the distal phalangeal, and this is a thinning of it looks like a pencil cup deformity. Onycholysis, nail pitting, and this is also onycholysis. This is the classification criteria for psoriatic arthritis. Casper criteria. Psoriasis, mutually exclusive categories for scoring. Current history given as a 2 points. Personal history 1 point. Family history, first degree or second degree relatives 1 point. Nail dystrophy typical of psoriasis, onycholysis, pitting, hyperkeratosis must be current. It is given as 1 point. Negative rheumatoid factor, any method except latex 1 point. Dactylitis, current or historical if recorded by a rheumatologist 1 point. Juxta-articular new bone formation, ill-defined ossification near a joint margin excluding the osteophytes on a plain hand or feet radiographs 1 point. As a classification of psoriatic arthritis is met if the final score is equal to or more than 3 points. The Casper criteria specificity is about 98.7 and sensitivity is 91.4 against the criterion standards, which is the diagnosis established by the rheumatologist. Enthesitis. Entheses are the anatomical structure formed by a tendon, ligaments, and a joint capsule insertion on bone. Inflammation of this entheses is known as enthesitis. They function together with the bone and synovium as a synovio-enthesial complex to distribute the biomechanical stress in a musculoskeletal structure. Enthesitis has an important role in psoriatic arthritis pathophysiology, with studies supporting a link between a biomechanical damage as an initiating event of autoimmunity in psoriatic arthritis. Clinically, enthesitis is diagnosed as a tenderness to pressure at the enthesial insertion sites. The most common sites involved are Achilles tendon, plantar fascia, lateral epicondyles at the elbow. Subclinical enthesitis demonstrated with the ultrasonography has been shown to exist in a significant proportion of the patients. Spondyloarthritis is defined as an inflammatory arthritis affecting the axial skeleton leading to spondylitis and sacroiliitis. An isolated spondyloarthritis or axial phenotype is rare in psoriatic arthritis and occurs in 2 to 4% of the cases. More commonly, axial psoriatic arthritis overlaps with the peripheral psoriatic arthritis, and 30 to 40% of people with psoriatic arthritis are affected. Risk factor for axial psoriatic arthritis are presence of onycholysis, inflammatory back pain symptoms, psoriatic arthritis duration and engaged onset, positive HLA-B27 and inflammatory bowel disease. There are significant differences between axial psoriatic arthritis and ankylosing spondylitis, which were explored in several studies. Ankylosing spondylitis is significantly more likely to present with bilateral sacroiliitis, complete ankylosis of the sacroiliac joint, and bridging syndesmophytes formed in caudal to cranial progression. More severe osteoproliferation than axial psoriatic arthritis. In axial psoriatic arthritis, likely to present with isolated spondyloarthritis, whereas in ankylosing spondylitis, bilateral sacroiliitis is seen, manifest with random syndesmophyte formation in axial psoriatic arthritis. and isolated involvement of the cervical spine. Although sacroiliitis is the most common symmetric, it is less likely than in ankylosing spondylitis. Axial psoriatic arthritis with isolated spondylitis is 4 times less common in axial psoriatic arthritis. Psoriatic arthritis, nail dystrophy, and arthritis. Sacroiliitis illustrated on MRI. Irregular and bone marrow edema. These are the eye manifestations in psoriatic arthritis. It is a posterior seneca and ciliary flush and large keratotic precipitates in the Alts triangle. Non-cutaneous extraarticular manifestations. Eye disease, eye involvement manifest is the in a third of the people with psoriatic arthritis and about 10% of the people with psoriasis. Blepharitis and dry eye. In addition, conjunctivitis, uveitis, episcleritis, scleritis, keratoconjunctivitis sicca, and keratitis is seen. Uveitis is defined as inflammation of iris, ciliary body, and choroid, and the prevalence is variable, estimated 7 to 25% in people with psoriatic arthritis. This is much less than in ankylosing spondylitis, where uveitis occur in 40% of the cases. Uveitis risk is higher in psoriatic arthritis than in psoriasis. There are differences in ocular manifestations of uveitis between people with axial versus peripheral psoriatic arthritis. In axial psoriatic arthritis, uveitis is diagnosed at younger age than in psoriasis, and the peripheral psoriatic arthritis more likely to present in males who are HLA-B27 positive and more likely to be involved in the anterior segment. In contrast, uveitis in peripheral psoriatic arthritis is more likely to be insidious, bilateral, and involvement of the posterior segment, perhaps because of the later diagnosis or increased severity of uveitis in patients with psoriatic arthritis is more likely to lead to ocular complication than in psoriasis. This picture denoting the engorged vessels due to inflammation and the posterior seneca and a pupillary membrane opaque pupil. Posterior seneca highly irregular, ciliary flush, and a large keratotic precipitates in the Alts triangle. Inflammatory bowel disease. Partially overlap in their genetic determinants, women with psoriasis and especially with psoriatic arthritis had an increased risk of incidence of Crohn's disease and psoriatic arthritis, but without any GI symptoms. Versus normal controls. All the psoriatic arthritis patients had a microscopic colitis with increased lamina propria cellularity and lymphoid aggregates. Additionally, majority had